All right, good afternoon, everyone. My name is Michael Liu. I'm the Dean of the School of Public Health here at UC Berkeley. And on behalf of our entire school community, 400 faculty and staff, 1,200 students, and 18,000 alumni worldwide, I want to welcome you to the inaugural John Swartzberg Lecture at Berkeley Public Health. I want to begin by thanking Richard Scheffler and all of our donors whose generosity and vision made this lecture possible. I also want to thank you all for coming here today. It means a lot to see this room filled with people who care deeply about our community, about public health, and the values this lecture series is meant to honor. It's a real privilege to introduce our keynote speaker today, Dr. Erica Pan. But before I do, I want to just say a few words about Professor John Swartzberg, in whose honor this lecture is named. Now, many of you know John as a world-class infectious disease expert and one of the most trusted voices in public health. But those of us who were his students knew him a little differently. You see, I was John's student in the Joint Medical Program 35 years ago. And for us, he was truly one of the best teachers and mentors one could ever hope to have. John is a gifted communicator and a master storyteller. His lectures were so spellbinding that no one ever fell asleep in his class. Well, almost no one. Sorry, that's a little bit of an inside joke. We also knew him as a mentor who cared deeply about you as a person and who inspired you to care deeply about the world just by the simple eloquence of his examples. I know that I'm a better physician, a better professor, and better human being because of John. About 35 years ago, when my classmates and I started the Suitcase Clinic, which is a student-run clinic for people experiencing homelessness here at Berkeley, which I'm proud to say is still running 35 years later, John was one of the professors we could always count on to show up as a preceptor. And in those early days, showing up mattered. It meant giving up your evenings, sitting with students, seeing patients who had nowhere else to go, demonstrating through action what it meant to be a doctor, what our social responsibility to our community, to our society, and to the world is all about. John didn't just teach medicine and public health. He practiced it, he lived it, he modeled it for a generation of students. This lecture is named for John not only because of his distinguished career, but because of the ideals he represents: service, teaching, mentorship, communication, and a deep commitment to health equity and social justice for all. Which brings me to our speaker today, because I can think of no one more fitting to give the inaugural John Swartzberg Lecture than Dr. Erica Pan. Dr. Pan currently serves as the Director of California Department of Public Health and our state public health officer responsible for protecting the health of nearly 40 million Californians. She's also a clinical professor of pediatric infectious diseases at UCSF. Now, many of us in the Bay Area came to know Dr. Pan during COVID when she served as the acting state health officer, state epidemiologist, and the deputy director of the Center for Infectious Diseases. During that time, she helped guide California through one of the most difficult and uncertain periods in modern public health. Those were not easy days. Those were not easy decisions. And what public health leaders had to do during that time required not only scientific expertise, but also courage, compassion, communication, and deep commitment to health equity and social justice for all. Prior to the state, she also served in multiple leadership roles in local health departments in Alameda County Public Health Department from 2011 to 2020, in San Francisco Health Department from 2004 to 2011. In many ways, Dr. Pan represents what we hope our students will become. People who use science in the service of the public good, who step forward in moments of crisis, who understand that health is shaped not just in hospitals and clinics, but in housing, schools, workplaces, and communities, and who are willing to roll up their sleeves, even in our darkest days in public health, to protect the health of the public, especially the most vulnerable. So it is incredibly fitting that a lecturer named after a man who spent his entire career showing up for his students and his patients is inaugurated by a public health leader who's now showing up for the entire state. So please join me in welcoming the Director of California's Department of Public Health and our State Public Health Officer, Dr. Erica Pan.
Great. Thank you so much. This is such an honor. Oh, great. Thank you. I'm just so incredibly honored. And I think, and John may bring this up again later too, but the other wonderful thing that unites John and I is that we also were very involved in the Schweitzer Fellowship. So I was a Schweitzer Fellow when I was in medical school in Boston, which was one of the first domestic fellowships where we had largely medical students and a few other allied professionals doing service projects and doing service learning in honor of Albert Schweitzer. And then in the Bay Area, met Della Ogar and John to work in the Bay Area Schweitzer Fellowship and on the advisory board. And now I'm on the national board. But I think just continues this theme of sort of service to our communities and really fostering and mentoring sort of many students here in the room to have a life of service. So thank you for this honor. So I will, let's see. So I'll just talk to you a little bit more about my personal journey. You've heard a little tidbit of that part, and a few insights into how we were thinking about the pandemic and our response and some of our strategies, and then a little bit about just the small kind of minor things that are happening in public health right now and what we're trying to do about it here in California. So this is sort of my personal journey slide, and actually, earlier in the timeline that's not on the screen, I already mentioned my Schweitzer Fellowship. So I was I did a joint MD MPH program at Tufts Medical School in Boston. And I think backing up further to that, when I was an undergrad, across the bay at the rival school of the UC Berkeley. But I was a reluctant pre-med and really, even then, really loved science and liked the idea of direct service, but also liked the idea of broader impact and broader policy. So thus I applied to joint MD MPH programs. And then I trained at UCSF in pediatrics and then pediatric infectious diseases as I was trying to find sort of a niche, but also one that really crossed over well with public health. And then after that is where sort of this timeline starts in San Francisco. It was interesting in 2003, 2004, when I was starting after my infectious disease fellowship, there was a lot of attention at that time to bioterrorism. It was a couple of years after 9/11 and the anthrax scare. There was a big smallpox vaccine planning that one of the Bush presidents wanted to do. And then actually our first scare with H5N1 was in 2005, and the first SARS-CoV-2 were in 2003, 2005. So there's a lot of work then happening related to infectious disease emergencies, bioterrorism, and a lot of funding and resources for that, and pandemic flu planning. So I started my career in San Francisco doing a lot of that, not because it was like the passion I had coming out of fellowship or anything else, but it was just where a lot of resources were. So ironically, spent a lot of time in San Francisco helping lead infectious disease emergency and public health emergency planning for the whole Bay Area, which becomes important later with another picture on here. But I had moved to Oakland, a couple of years after I started working in San Francisco, and a position opened up in Alameda County to be a deputy health officer overseeing all of communicable disease control and prevention and emergency preparedness and the labs. And it was a perfect fit, actually. So I spent a lot of time in Alameda County from about 2011 to 2020. And that's where my other namesake, I'm not related to Dr. Richard Pan. Actually, he pronounces his name Pan, and I actually usually say Pan, and we are not related, but he's been a real also mentor and champion of immunizations. And I had the opportunity as a local health officer to testify for some of his really important state vaccine requirements in California. And that was where I also got just more and more interested in having impact on legislative policy, being able to testify for those kinds of things, and in a statewide impact as well. So that's a picture with him during that. I also happened to do a really useful fellowship at the California Healthcare Foundation, where I worked a lot across sectors. There were only a few public health people and mostly direct healthcare providers, and continued my clinical practice at UCSF during that time, initially in San Francisco and then at Oakland Children's after that. And then around 2018, the health officer in Alameda County moved to LA, and I became the acting health officer for Alameda County. And then I think this picture on the stage was a pretty life-changing moment for not only us of the 7 health officers in the Bay Area in March 2020, but for sort of all of us in this room, no matter where you lived. We were the first 7 Bay Area health officers to issue a stay-at-home order in the nation in March 2020. And I'll tell you more about that story in the follow-up slides. And interestingly, Dr. Aragon, one of the gentlemen in a white coat there, was the San Francisco health officer at the time. So we worked closely together, yet another important sort of mentor and colleague. And we had worked together closely across the Bay in different ways over the years. And so I think that really made it more helpful to us as a group of health officers that had worked together for years to make that really, really difficult decision. So that was in March 2020. And then July 2020 is when I had actually been interested in the state epidemiologist position that at that time also oversaw the Center for Infectious Diseases. And I knew the prior person was retiring in 2019. So I'd been really interested prior to the pandemic. And it had just taken them a while to sort of post and recruit. So in the middle of the July surge in 2020 is when I left Alameda County, which was, hard to do in the middle of that time as well. But I also felt like if I'm going to be working this hard, I can serve even more people if I can come to the state level. So that other picture there is me getting sworn in by Dr. Sonia Angel, who was the state health officer and director at the time. And the only people in that room could be the 2 of us, 6 feet apart with our masks on, and one photographer who took that photo. And then they whisked me off to the Emergency Operations Center. And then fast forward a little bit further. So I spent that time during the pandemic, which I'll talk more about. And then last January, Dr. Tomas Aragon, who had joined the state in 2021, retired, and I was appointed to be his successor. And this is Kim Johnson, who swore me in as the director and state health officer. And it was so nice because my family could be there. My husband came up, my younger daughter, my older daughter was away, but could zoom in, and a bunch of our team from CDPH. And it was just a really warm, wonderful moment. And it strikes me when I talk about this, how different those 2 experiences were. So now shifting to tell you just a little bit more. So, it's hard to remember now, right? I can't believe it's been 6 years actually, but there was a Sunday that I, of course, remember vividly. We had been working and thinking together across the Bay about different things. I remember earlier in February having to cancel the St. Patrick's Day parade, right? It was, earlier than, but realizing we were starting to say no more gatherings after, beyond 10,000, beyond 1,000. And we were starting to get to sort of smaller and smaller numbers of gatherings that we said we really should stop doing. And then it's also really interesting that the San Francisco School District on March 13th, which was the Friday before this Sunday, closed the schools because they were worried about a small respiratory outbreak and they were waiting for the testing to come back. The testing actually did not come back as COVID, but they closed that school district before the testing came back. And then it was just a cascade across the state. And I think it's important for people to know that many people in public health, including myself, and including this group of health officers, really want to do everything we could to keep schools open. And that decision was actually a school district decision. It wasn't a public health decision necessarily, but it just cascaded so quickly. So that was an interesting moment. And then the other important thing that was happening in Santa Clara County is not only did they have some of the first cases, and as you all may remember, we didn't have enough testing, right? We were flying blind a bit and not knowing really strict criteria because there weren't enough tests to only test really seriously ill patients. And Santa Clara was able, though, to put together a community surveillance. And this is why, again, to public health students and those of you in public health and learning about surveillance, it's so important. They did a community surveillance project where they were able to test some outpatients and do it in a systematic way. And they saw evidence of COVID transmission that really meant it was already spreading in the community. So between that and looking at the numbers, that was when Italy was really starting to escalate too. And we were starting to hear and see stories in Italy about people sharing ventilators. They didn't have enough beds. And so we're watching those numbers and looking at our doubling time. And so we had a conference call at noon on a Sunday, and then made that really hard decision that if we didn't take action now, we would really be, that this was really escalating exponentially. Again, looking at those doubling times, that we really needed to flatten the curve, which I'll talk about in a moment. And then, but the other phenomenal thing that I just want to share was that we had this conference call. We made that hard decision relatively quickly amongst the 7 of us to do this together. And then we managed to let our legal counsels know. Eventually later on, our communications people, we had to notify our boards of supervisors in San Francisco. They needed to let the mayor know. And we managed across 7 jurisdictions to come up with a common health officer order in 24 hours, basically. I mean, those lawyers worked all night. We were able to agree. I mean, this is just very unusual circumstances, especially any of you who have to work with legal sort of documentation, but we had to issue this in a legal way and agree across 7 jurisdictions. And it was phenomenal that we managed to do it in that 24 hours. And then this stage moment in Santa Clara County was, I think, literally 24 hours later. And then we told everyone, by tomorrow, we need all of you to stay at home to really stop the spread of this disease. So I think, just to highlight, that's kind of what went through our heads, what was happening. And of course, the other thing that we always see on these curves about flattening the curve, like if you can do social distancing, if you keep people at home, you can flatten the curve and delay things until you can better understand the disease, better work on other, treatments, medical countermeasures, right? You want to develop treatments and vaccines to prevent this. And you're also protecting the healthcare system. Again, what we were seeing in other countries was an overwhelm of the healthcare system. And we already know that in the United States, we can barely, deal with sort of big winter surges at the same time. And we also knew we had a lot of data from the 1918 flu, and that cities and jurisdictions that issued these stay-at-homes sooner did better. They bounced back quicker economically and health-wise. But there wasn't a lot of data about how do you reopen safely, and it was so much more complex in 2020 than in 1918 to think about the different kinds of settings that you start to reopen or that you start to bring people back into. So I think it's just a really important thing to let you all know too, as we were, we too thought, oh, we'll do this for a few weeks, and then we'll start to lift and we'll figure out how to do that. And then as soon as we started to, we saw that resurgence. And as you all know, we just sort of kept having these different surges and then different variants. So that was a little bit of just the rationale and what we were thinking in that moment. And then just to kind of highlight some of the strategies when I came to the state, really worked with our teams and at all levels to come up with some strategies and goal areas. So these are all incredibly important. Communications, first and foremost. Another thing I think I share a passion for with John, how important communications are and how to do that in plain language. And I still know we need to do a better job of this, which I'll talk about later. Vaccines, of course, and then surveillance and suppression. So really thinking about testing and surveillance and how do you continue to monitor the scope of the pandemic and then do your interventions in a strategic way. And of course, once we had treatments, testing to treat, and equity was first and foremost also, and I'll talk some more about some really specific efforts we had that focused on equity. And then of course, just thinking about all of these mitigation efforts that are non-pharmaceutical measures and the policy and science, and being able to do everything we could and learn as much as we could from our partners, both within this great state and across the country and the world, to do the best we could on what we thought were the best interventions. And then schools were a call out specifically, because we all know how important it is for our kids to be in schools, and really working to have safe and successful schools was a big focus. And then obviously healthcare and medical systems and, prevention and care, and dealing with all of these surges and trying to help, with our other partners in healthcare on not only preventing any surges, but when we had them, helping try to redirect patients to offload the unevenness that can occur with that patient surge. And then of course, just coordinating it all is a ton of work, but those are kind of the key areas that we did. This is a complicated slide, and I don't, I know some of you probably can't even read it very well, but just some of these key timelines. So, everything from that first case, confirmed case at the end of January in California. There was a state of emergency declared. One other just random tidbit too. I remember when we had our first case in Alameda County, when I was Alameda County Health Officer, it was a very anticlimactic weekend when we had our first case confirmed. And so I like signed this declaration of an emergency in my office with like our deputy health officer, but it was just very, there was just so much going on. It was a weekend. But that was when, in the Bay Area and in general, I think a lot of jurisdictions declared the emergency when they had their first case. And then, of course, the blueprint, which I'll talk about, was when we started trying to reopen again in August, which was one of the first things that when I came to the state, we started working on again. There had been some other different attempts at trying to reopen, but we said we really need to be even more strategic and methodical about reopening. So that was the blueprint for reopening in August 30th. And then we had some equity measures, which I'll talk about in a moment. And then, of course, vaccines came in December, and we were all really hoping that that would be the next sort of, this will get us through this. And then you can see, though, of course, all these different variants, and Delta, of course, is the variant that then had learned how to outsmart our vaccines. And then later isn't even on here, the Omicron, which really caused quite a surge as well. So it's just sort of a helpful timeline and a great paper as far as a reference. And just to highlight a few things, both either for how we incorporated equity into our strategy, and then when I get to this sort of mask MMWR, it was a great collaboration with UC Berkeley. So I just wanted to highlight, but as far as our blueprint for reopening, how many of you were here in California in 2020? Most or many of you, it looks like. Yeah. So you probably remember this. And you may also remember that at the federal level, there was not a consistent strategy or markers at that time in 2020. So every state was kind of doing our own thing. And we were all talking to each other, but there wasn't really like, anyway, I see heads nodding. So we came up with, after lots of discussion and vetting, again, with partners all over the country, some tiers of, purple was the most stringent. And then once you got to a certain case rate and a certain test positivity, you could start to reopen certain things. Like, one example might be you can start to have outdoor dining again, or, things started to, and so we had different tiers of things that you could start to do again in different counties. And California has 58 counties, so we did it based on those counties. And that was sort of our strategy of trying to do this in a really methodical way. And then if, as a county was reopening, if their numbers got back to, like say you got to orange, but then your numbers got back to red level again, you'd have to go back to that red level. And so every Tuesday, I don't know if anyone remembers Tier Tuesday, but that was like the day the county numbers would come out. And we had, tons of epidemiologists like looking at not only receiving all this case data, but, trying to make sure we had these numbers right. And it came down to, for different counties, 0.01, sometimes whether you were red or purple, and that made a big difference. So it was really important that we were doing that well. And then as far as equity, I am really proud that, and as far as I know, we're the only state that really integrated it in this super methodical way. We then developed, soon after we launched this blueprint, we came up with an equity measure, basically to say that we looked at Healthy Places Index, thanks to the Southern California Public Health Alliance. And Healthy Places Index is a social vulnerability index, and looking at the quartiles of sort of the least healthy places to live, everything from, economics, education, environment, race, ethnicity. So the sort of the most privileged versus the least resourced. And we said that for each county, in order to move forward from, for example, purple to red, not only does your over countywide numbers have to meet these case rates and test positivity, your sort of least resourced quartile 1, has to also meet that metric so that you're not leaving that population behind. And as we all know, that was the population that had the most disease. So it was really a way to try to mobilize the entire county to really help make sure that they were disproportionately attending to where there was the most disease, and doing it in a really sort of objective way. So that, and then we also had different equity metrics related to vaccine release and how many vaccines were distributed in different quartiles. And I'll talk about, this has one way we were doing that for the statewide numbers. And then we also allocated within jurisdictions based on an equity metric as well. And then I just wanted to highlight, one, because masks are certainly controversial, but two, this was a really nice, this community mitigation NPI measures slide was a really great collaboration with UC Berkeley School of Public Health, and helped mobilize, I believe, a bunch of students as well to do case control study where we looked at interviewing test positive and test negative Californians, and then asking them about their mask use. And we did see basically what I would call a sort of a dose response that, and we know this, but we were really able to show it in practice as opposed to just in a lab, that N95 respirators were, much more protective and least likely, people would be least likely to be infected if they were wearing a respirator, but a surgical mask was still somewhat protective and a cloth mask was still somewhat protective compared to no mask at all, and really showing that sort of dose response. And again, it was just a great academic collaboration with our partners here at UC Berkeley. And then back to vaccine allocation strategies. So we also very deliberately, when we had vaccine, looked at allocating and distributing in the 4 quartiles. We said 40% needs to go to our quartile 1, or at least healthy places index, and then 20. That being said, that's just one piece of how this all gets distributed, and what gets into arms still means you, in those jurisdictions, you also need to have culturally appropriate providers doing the vaccine administration, having the languages available, having hours available. So, and I guess not surprisingly, but what we also saw was people who live in sort of the healthiest places were driving to the clinics that were in these in the least healthy places index quartiles. But it was at least one layer of an attempt to really be very intentional about disproportionately providing a resource to the populations that had the highest disease burden and the least resources. This is just another nice sort of a couple of things here. The Big Cities Health Coalition, which is about 13 big cities across the country, actually, including Oakland, Santa Clara, San Jose, and San Francisco. They tried to do an estimate, and of course, these estimates are really hard, but of what the impact of staying home for 45 days would be. And so their estimate was that it saved over 230,000 lives and prevented over 2 million hospitalizations. And they did this estimate within the first few weeks to really try to demonstrate, again, and at the time, I think when this came out, there was less, it was still early on and there was not pandemic fatigue yet or as much pushback, but we also wanted to try to estimate, what is the impact of doing this? And it's just nice to be able to have some numbers around that. This other graphic is just to share that the World Health Organization has put together a public health social measures decision framework. So we didn't necessarily have this when we were doing all of that in early 2020. Although I will say, back to the Bay Area health officers, we had been doing pandemic planning, and even in my role in San Francisco, doing a lot of coordination around pandemic planning ever since 2005. We had all worked together during the H1N1 pandemic in 2009. So we had some model orders and things like that, but there were so many new different things about SARS-CoV-2 that were different than some of our influenza planning. But it's just nice that there's this new kind of implementation package that the World Health Organization has put together to think about public health risks, contextual factors, evidence of the effectiveness of these mitigation measures, and thinking about those unintended negative consequences. We're certainly continuing to learn, right, about some of the unintended negative consequences of what our intervention measures were throughout the pandemic. Feasibility, of course, is always incredibly important. You might have a great academic idea that on paper looks great, but trying to actually implement it and having the resources to do it is the other layer of that. And acceptability, and that is more important than ever right now. We really need the public to, we learned also as well that public health authorities only go so far, right? We don't actually have necessarily enforcement, or that can really vary, as we've seen across different populations. So, you really need to work and communicate well for acceptability. And then, of course, that is hand in hand with community engagement. And then, of course, thinking about the ethics of any kinds of interventions you're going to do in these big pandemics or other large outbreaks. Another just sort of impact slide I wanted to share was this was a collaboration actually with some partners at Stanford in our immunization branch, but looking just from January 2020 to mid-October 2021 of the vaccinations we delivered by then, that we had averted over 1.5 million cases, over 72,000 hospitalizations, and over 19,000 deaths. So just, again, nice to have some impact numbers of what our interventions did. And then just to sort of highlight again, there are these classic curves about pandemics and trying to flatten the curve, and then the trying to reduce that, and then having resurgences again and suppression, and then trying to get to recovery. So this is just sort of highlighting these sort of known phases and thinking about them. And as we were winding down from the pandemic and trying to sort of bring back SARS-CoV-2 response into, regular health and healthcare and public health activities. We started to try to integrate those activities into permanent public health things, expand and leverage a lot of the gains we made for use with other infectious diseases. That's been especially highlighted in so many ways, but especially with our data systems. We built very quickly, which never happens in public health or government, some great systems that are really important for all kinds of diseases that we are still struggling to maintain as far as resources, and just continue to build our teams for resilience for future emergencies and try to recover. And then, of course, the healthcare systems also had gotten used to over 2 to 3 years, public health doing all of the vaccination and the testing and the treatment, and really trying to work to integrate that into regular care took some time. And of course, we still, I think, have challenges getting adequate treatment for people with long COVID. So we developed earlier on, this is actually a later version of the SMARTER plan, but I think it was 2022. We worked on a SMARTER plan, and then we've evolved it to a shorter version of SMART. But just again, as we were thinking about bringing SARS-CoV-2 virus and COVID-19 back into how do we think about this in relation to flu and RSV and other big respiratory viruses? We still think about vaccines. We still want to minimize risk. We want to continue to have awareness, good surveillance, good respiratory virus trends in the communities. Now we have tools like wastewater surveillance, which was definitely another tool born out of the pandemic, and continue our readiness and response. And we were already worried about the funding cliffs and other things. We were given so many resources to respond to the pandemic, and then they were already had cliffs or were decreasing, and then we had even more decimation in the last year, which I'll get to. And then, of course, testing and treatment. So these were just sort of a big picture approach of how we were thinking about it as we evolved out of the pandemic. So, I think there's so many lessons learned. I could talk about all of this for hours, but adapting to a novel pathogen as it evolves. So we know, especially those with infectious disease, these viruses are smarter than we are, and they continue to change, and we have to do everything we can together to learn. And getting to communication and partnerships, we have to be able to acknowledge what we know and what we don't know, and help people anticipate and help give people rationale on why we're recommending or doing specific interventions. And I think really important, and more important than ever now in our current environment, partnerships, and just how we are so much stronger together to continue to try to sustain trust, which we have clearly lost in some communities in public health. And then, again, this lesson of addressing equity will benefit all. And again, this is so important. And I'm so proud and happy that in California, we can continue to make sure that that is a core part of our work in public health, but is obviously a threat. And just, again, trying to continue to improve using the tools and lessons we've learned to mitigate other infectious diseases. We know there will be another pandemic. People already forgot about the 2009 flu pandemic, and it certainly wasn't as severe as the SARS-CoV-2, but every 10 to 20 years, there are pandemics. So, and I am speaking to the choir probably here because you're here, but, my work right now is so much about trying to tell these stories so that people do invest in public health infrastructure and systems. At one bipartisan biodefense commission I went to a few months ago, I tried to break it down to people. We need a strong workforce. We need trained workforce. And we can't just keep having these panic and neglect cycles where we can hire people and then they lose their jobs and then we need to train them again. Public health is a really important, unique role. And data systems are critical to actually do our job well. And of course, lab capacity, and we've learned some lessons even with MPOX after the COVID pandemic to do some of that surge capacity better. But, and of course, right now it's important to be telling people that vaccines work. So this is just a fun, some of you may have seen this during the pandemic, but I just, I sort of, I think it's very, it speaks to me about how do we know if these guidelines actually worked? Well, people would think you overreacted. So that's kind of what happens often in public health, right? And many times, when we're doing our job well, it's a silent success. And so when we're trying to be really aggressive, we're told we overreacted. So let's see, how am I doing? I'll try to speed this up. So, very tired after the pandemic, and then 2025 came, and not only were we with a new federal administration and a new secretary, we were kind of charting uncharted waters, and in a storm, and they're dismantling the hull. But we have a great crew, and that's again where I'm just grateful that there's a public health community here. Just to quickly kind of talk through, I think there's just a lot of changes happening at the federal level. I won't read these to you because I'm realizing I'm taking longer than I planned. But I did want to say a bright spot of what we just unveiled this in December of 2025 in California, is an initiative we're calling the Phoenix, which is not an accident. We're trying to rise out of the ashes of what's been happening nationally, but a public health network information exchange. So just briefly, this is 3 big pillars is the way I think about this. We're really focusing on innovation. And we want to, and we're working with Dr. Susan Collar-Menares, who was briefly the CDC director, but who had also worked at ARPA-H on really trying to do translational and implemented research. We're working to create an innovation institute with a focus on data technology and really work harder to bridge across private sector, public sector, academics, and philanthropy. So that's the innovation piece. And we're hoping that will help us figure out a more sustainable sort of funding structure too, if we can work more with like business models for public health and healthcare. And then collaboration is where we've done a lot of work. Again, we are stronger together. There's a West Coast Health Alliance, there's Governor's Public Health Alliance. We've joined the World Health Organization Global Outbreak Alert Response Network. There's also a Public Health for All Californians Together coalition, which is a cross-sector coalition within the state of California, really trying to bring together healthcare payers, healthcare systems, our chapters at the state level of the medical professional organizations, community-based organizations, to really try to make sure we're creating a network of networks as far as public health champions who can get information from us and help translate that to their communities, help clarify a lot of the confusion that's happening, and a lot of other partners. And then as far as communication, we're really excited to work with Caitlin Gentilini at your local epidemiologist. How many people does anyone subscribe or see? There's a handful at least. So she's an amazing communicator as well and lives in San Diego. So she's a Californian, and we're working with her on a project called Project Stethoscope to better do really also meeting this moment of people don't read a newspaper anymore and they don't watch the evening news as much. It's really like people are getting a lot of their information through social media, podcasts, and other things. So they're helping us. We're about 3 or 4 months into this, where they're giving us monthly reports of social media monitoring. What are the questions people have? How are certain messages we are putting out landing? And we're getting more feedback loop on that. And also helping us develop this community messenger network. So this is also just other ways I was highlighting that, and the kinds of partners we want in the FACT Coalition. So this is our page, Public Health for All Californians, that talks about a lot of these initiatives and also helps clarify. When we did we had a bill that we passed last fall also to remove ACIP from requirements for insurance reimbursement and point instead to California Department of Public Health, and we're in turn pointing to other national professional organizations. And then I just love sharing this. So this was, we had a Zoom press conference when we were unveiling the Phoenix initiative. And this is sort of, it says practice session because it was like before we opened it up to do like the public part of it. But it was just a moment of joy because we were all so excited. And specifically the governor was saying, I've never seen anyone. I was just super excited about this, and that we were getting to work with Dr. Menares. Dr. Deb Harry was the CDC chief medical officer who resigned in protest of Dr. Menares' firing, and she's been helping us with a lot of those collaborative multi-state global efforts as well. And Caitlin, and then Secretary Johnson was on there, and the governor was saying, I've never seen Dr. Pons smile this much. And then he was kind of muttering like, I guess that's because I mostly saw her during the pandemic. But it was just a really nice moment that I love to share. So we're hoping with Phoenix, I mentioned I feel like they're dismantling our hull, that we're going to come up with a hovercraft. So we are working together on that. We can do it with a good crew. We need good people. So I'm so happy to see a public health community here. Just some few acknowledgements here. And then I know later we'll get to a panel. So maybe I'll turn it over to John. And I just want to, again, John has been such an important, even when I was in Alameda County, was often a really important spokesperson for so many important public health communications, and a colleague at the local level too, and through the Schweitzer. So I'm really honored to be here and so excited you have this lectureship, and so honored to be here in your honor. So turn over to you.
Thank you so much, Erica. There wasn't a lot to be comforted about comforted by during those years, dark years of the pandemic. But the one thing that was very comforting was knowing you were in charge. It really was. In addition to Erica on the panel, I want to introduce two other panelists. Throughout the pandemic, I had the privilege to speak with lots of journalists, and I enjoyed that. They were almost every one of them were excellent. But the two that I love the most by far are sitting up here. Really, without exception, their work was outstanding. So let me tell you a little bit about them. I'm going to start with Erin Allday. You probably know her name if you read the San Francisco Chronicle. She's been in her 20th year as a reporter for the San Francisco Chronicle. At the start of the pandemic, she had been a longtime health writer focusing on infectious diseases, so she was really well prepared for the pandemic. Erin has lived in the Bay Area since graduating from UC Berkeley, and she calls Berkeley her home. She started her journalism career at the Daily Cal. I first met Erin in this auditorium, and she reminded me it was right around Valentine's Day of 2020. Art Reingold was giving an update on this brand new virus that we didn't know anything about. And he invited Erin to come and talk a little bit about communication, which is really the theme of this meeting today. I introduced myself to you, I remember at that time, and thought, she's really good. And she sure turned out to be during that pandemic. Since then, we've spoken innumerable times on the phone in regards to the pandemic, and she has a unique capability of taking information, talking to people, taking that information, communicating in writing to a way that is easily digestible to the public. The other person I want to introduce, my other really special journalist, is Brian Edwards-Tiekert. Brian joined KPFA as an intern in 2003. He must have been pretty young then. Early in his career, he was an environmental justice reporter and co-host and producer of the morning show. In 2016, he was awarded a John S. Knight Journalism Fellowship at Stanford. He returned to KPFA after a year at Stanford and is currently the host of KPFA's Upfront. I first met Brian almost exactly 6 years ago. He invited me to answer a few questions in a morning radio show that he had about COVID. This quickly evolved into an event that continues to today. They're called COVID calls every morning at the primitive hour of 7:30. Of course, people call in and ask questions about COVID, and Brian and I try to answer them. Now it's evolved into COVID calls and other infectious diseases. Brian is an absolutely outstanding communicator. He can translate in real time complicated and arcane scientific and social information into an easily understandable message. I am in awe when I'm on those shows and trying to say something in a bumbling way, and then have Brian just simply translate it so beautifully. So I'm thrilled to have both of you here, and I'm really honored that you came along with Erica. I had a bunch of questions that I wanted to ask the panelists, but I suspect you guys do too. So I have a microphone up here that I can bring around. Are there some questions that anybody has?
Thank you, Erica. That was a really wonderful talk, and I appreciate it a lot. I want to ask you about preparedness, because there were two things we learned during COVID that I found a little troubling. The United States maintains a stockpile of supplies, and it's intended for bioterrorism, and it's also intended for outbreaks of infectious diseases. And we discovered that the cupboard was almost bare. You'll remember going online to look for N95 masks because we kept hearing that we were supposed to have them, and yet they weren't available. And there were other examples. So my question about that is, does California maintain a stockpile? And if we don't, should we? My other question is about data, because the other thing we learned was that we didn't have the infrastructure in this country and probably in California to exchange information about outbreaks of disease. So the hospitals couldn't tell the public health officers, who couldn't tell the clinics, and it was just almost like word of mouth. And now at least we have wastewater analysis. But my question is, has there been a push to improve that data infrastructure so that the next time we could gather information more quickly and more accurately?
Very important and good questions. As far as stockpile, the other interesting thing is with N95s as an example, they kind of expire, and it's all about like the elastic on them that they can't be a good seal. So there were a bunch of expired N95s in many, both local and state and national stockpiles. And this, of course, is one of the issues, is rotation of things that expire. So the federal SNS does some of that, but that also is diminishing. The state still has, I believe, some antivirals from even as far as anti-flu antivirals, that the shelf life has been extended multiple times. And then what you may or may not remember too is the state ended up working. It was right before I joined the state, but started actually, as far as N95 started, had a huge contract, I think from a manufacturer in another country that they managed to get here. There were some interesting lessons learned there too, as well, around making sure the right subject matter experts were helping vet those. I think we still have a much smaller amount of N95s in that stockpile now, but it is not as robust as it probably could be. And I do think, I've always thought that what needs to happen is better partnership with the private sector here. Organizations that will continue to use them and rotate them. And I don't think that has happened effectively yet at any level, but I do think that would be the right solution. And just hasn't, with a lot of distractions of defending other things, hasn't been able to be. But I do think that would be, and there were some creative things like that, even with the H1N1 2009 pandemic, that were the start of that. But I think sustaining, the other problem in public health is sustaining in general, which is part of the data system question. So yeah, huge bolus of funding and resources for these systems. We in California now finally can have like a cohesive statewide immunization registry. It was regional before that. As far as our data surveillance systems, one way I describe it is we had a very, very old system, and then the gateways to it were not prepared for the millions of cases that were coming in. A lot of reportable diseases are much smaller volumes, so the gateway actually broke in August 2020. There was another one. I started in July, and that broke like a few weeks into my tenure, and so we put a lot of patches on it. We fixed the gateways. We added a much better response system to do like contact investigation, contact tracing, contact monitoring, outbreak investigations and modules. And there's a real blend of federal and state funding for all of these, although a lot of it was federal. And then many of those were set to end this year, actually in June 2026. And then there's been some gradual state investments as well. But this, the other thing I say a lot is, I thought the one thing that might help us with this panic and neglect cycle in public health would be a once-in-century pandemic with this magnitude. And in fact, it's done the opposite. And I actually do think the lesson learned is communication. So I look forward to hearing more from our panelists. But our data systems are also at risk. We're still kind of getting funding year to year, which is the other reason we're trying to do this Innovation Institute. Like, we have to do this a different way. Like, government is already behind, and now we have technology exponentially changing around us, and we're going to get left behind unless we start thinking about how to do it differently. So thank you for those questions.
Actually, I'm going to take the liberty of being up here and ask Erin and Brian to chime in on this idea that with all the changes in scientific information that was just coming out like floodwaters during the pandemic, how did you balance what you were hearing with the idea that some of the stuff could be really alarming to the public? And how do you make the judgment as to how you're going to frame what you had to say, both in the written and verbal media, to not alarm too much the public, but at the same time to inform them? What was going through your head during those crazy times?
I guess I can start. I will say, sorry, that early on, that wasn't much of a concern. If anything, I had like a long practice and habit of learning to de-escalate and like not make things, too alarming. And it was kind of the opposite, if anything, where in fact, I remember in that February talking to a lot of folks, experts like yourself, who were like, I don't think that this is really going to go anywhere. Like, I think we're going to be okay. Like, they were trying to tone it down. And I was kind of in that space. And it was actually, to me, a lesson in amping it up, being like, no, actually, now is the time to be alarmed. And that was sort of a different headspace to be in. And I think I felt that with a lot of the health officers I talked to, where everybody is always very cautious with their language, very much not wanting to get people upset unnecessarily. But here was a thing where you actually needed to activate that. You needed people to be alarmed. And I will say, in the Bay Area, I do feel like people approached it with the appropriate level of concern. I do think it helped that we have a very educated population here who was used to getting information from their health officers and using that information. So we were kind of lucky, I felt like, certainly for the first part of the pandemic, that it felt like we had a very engaged audience that very much wanted this information and was taking it the way it should be taken. They were taking it seriously with the appropriate level of concern, but they also weren't, I didn't get like a lot of people panic, a lot of people losing their minds over this. I felt like people, like I said, at least at first, were kind of handling it appropriately. And yeah, like I really kind of had to put myself in a space of like not tampering it, of kind of, ramping things up a bit.
Yeah, I think so we're in an unusual situation. The show I work on in the morning at KPFA mixes local, state, national, and international news. So we first started covering COVID as a foreign news item in China. And I can vividly remember, I just looked it up, February 10th of 2020. We were interviewing two reporters, one in Beijing, American reporters, one in Beijing, another was a freelancer covering Shenzhen from Sichuan, and had been caught in one of China's lockdowns, I think. At the time, there were like 700 million people who weren't supposed to leave their apartments. So he was describing the day-to-day, which made a really big impression on me and my co-host. And I remember kind of marching out of the studio upstairs to our general manager's office and saying, we should probably start limiting gathering sizes in the station and talk about what technical preparations we need to make if people need to start broadcasting from home in the near future. And so actually it wasn't alarmism, but the coverage drove the policymaking at an institutional level. And it was interesting to me to think back on it, how the information did that. As we moved into actual impact here, the focus I kept coming back to was on the pandemic, not as like a strictly biological phenomenon, but as a social phenomenon. Because what we knew about the virus, you could fit into a 15-minute interview, and we had an hour a morning to fill. And what was much more interesting was how people's lives changed, and also kind of what we owed each other at a time when we were all facing the same crisis, when people had very diverse vulnerabilities and exposures. And I think constantly framing the coverage around what we need to do to keep each other safe, the same way I thought when we were discussing internal policies at our station. What am I doing to keep Eileen, our, at the time, 68-year-old morning news anchor who couldn't do her job from home? What are the rest of us doing to change what we're working to keep Eileen safe, doing a job that lots of people in the public count on? So as a framing it as a social phenomenon, I think put the alarmism in context. And there's a temptation to say, be scared of this. Here's what you can do to protect yourself, to play fast and loose with what you can do to protect yourself, because there are a million people that are happy to sell you snake oil, right? And easy cures and preventions. And, you know, talk more about how we show up for each other, masking not just as something that lowers your risk of catching a disease, but lowers your risk of passing it on to someone who you don't want to make sick. And also a focus that shows up a lot in Erin's reporting as well, on people who are especially vulnerable. And at the time, when there's a shelter-in-place order, well, what does that mean for people who don't have a place to shelter in? You know, who in bad weather would be in congregate homeless shelters? When we realized that this was an airborne phenomenon, what did this mean for people in prisons? You know, we saw what it meant in assisted living facilities because we had more visibility into them. We have horrible media access inside this country's prisons and jails. So those were the, I guess, kind of my North Stars in terms of prioritizing our coverage. And I think when you tell people, here's what you can do, and here's what you can do to be socially useful, there was this incredible blossoming of like bottom-up mutual aid efforts. I mean, down to my neighborhood level, you know, people who didn't have comorbidities going shopping for people who did, and leaving groceries on their doorsteps. And it was inspiring and really, I thought, important to focus on.
Thank you. Other questions? I have more. Yes, Ed.
So public health officials, scientists, and so forth, they're not homegrown. They come from academic institutions and they find jobs all over the country. But one of the things that I had noticed in the pandemic was the impact of politics and economics, lifting of restrictions for the business people in their states. It became a real dilemma because we had a chance to tamp down and mitigate, but we found certain areas where the politics were interested in supporting the business more than they were in supporting public health. I was hoping the panel, because we have such a diverse set of approaches, might comment on that.
I can start off just one quick thought on that. I will say in the Bay Area, early on, the politics kind of worked in our favor because there was a lot of sort of, you're in this corner and that corner. And so I felt like we had a lot of people here who were like doubling down on the pandemic protections because it felt like a political statement. And so that was sort of my experience, which was interesting early on, at least in the Bay Area and kind of in California. There were obviously pockets of California that wasn't the case, but kind of throughout the state, it became this us versus them, which sort of worked in our favor for a little while. For me, that stuff didn't become more of an issue in the Bay Area and California until the reopening period. And then it became a lot more complicated because there were understandably, there's a lot more nuance, a lot more kind of place for people to come in and say, but maybe this isn't quite the right take. And so then it became more complicated. But in the early phase, that was my experience.
I think it's, oh, sorry. I think it's important to remember that, like, here in the Bay Area, the major tech employers started sending people home before there were any public health orders telling people to stay home. And we discovered after the fact that, in fact, London Breed had been in conversation with several tech executives saying, you guys need to do it first to get people talking about this, so there's not such a backlash when it comes from a government authority. And I think, like, a lot of the businesses that were really hurt are the ones that aren't particularly politically powerful. These are the restaurants, the bars, the small businesses that depend on foot traffic. The biggest employers in the Bay Area worked quite well with the transition to remote work, and a lot of them have largely stuck with it because it serves their workforces. I think that the bigger issue we found with the reopening, Michigas, that you got into is that we didn't have a good way of responding to all the hardships created in people's lives by those interventions. Like switching to working from home worked great for me. My wife and I have enough space. We like each other. Like we could both work from rooms where the doors closed. But I had like no insight to what it was like trying to be daycare and an uncredentialed teacher for a child who'd just been sent home while also continuing to perform my job. You know, I couldn't tell you what it would be like being stuck in the house in an abusive relationship. And so where you really, it seemed to me, saw this backlash starting to build was among people whose lives had been upended by the closures of these public institutions that are part of our safety net and that provide a lot of services beyond what it says on the tin. Like our schools, they don't just educate kids, they feed kids, they provide social services to kids, they intervene when there's signs of abusive kids. And suddenly that was cut off from a lot of people at once without a long-term plan for how you meet the needs that weren't being met.
A couple other thoughts I'd add about businesses, and it's actually a good segue to some thinking now, but and I think it's a little bit easier at the local level. Like one of my colleagues who was on that stage, Dr. Matt Willis in Marin County, really got, and because Marin County is also a smaller county, got a lot of his business partners to the table very early on. This is why we're doing this. And also coming up with solutions, right? I think that is where engagement is really important because especially the really resource businesses, but even the others, if you can have the resources to engage well and early on, here's what we know, here's what we don't know, here's what we think would be helpful, you know, they can help come up with the solutions too. And I think I do wish, as another lesson learned, we could have done more of that. And when we started doing more of that, I think at the state level, but again, it's such a big state and there's so like a restaurant in one place is a restaurant. Like there's so much diversity even across how a restaurant is structured. But I do think being able to work with them about that and engaging businesses earlier could probably be helpful. And I think in places that did it earlier probably was more helpful. And then it's interesting, just like fast forwarding to now, as I've been reflecting a lot on shrinking public health governmental resources, trying to think about how do we engage, like everybody wants people to be healthy, right? I can't, you know, regardless of your politics, I don't think anyone would say, I don't want to be healthy or my family to be healthy or my community to be healthy. There's of course a lot of disagreement on how you get there, but businesses care about that too. And as I think about, we have to protect for government public health, we have to protect the protective work, like disease investigation, outbreaks, keeping food safe, keeping water and air safe, but promotion and healthy like promotion, I think the healthcare sector and other businesses need to help more, especially if we do continue to get decimated. So starting to try to think about that, but would love, you know, I think this is something we should all be as a public health community thinking more about how do we engage? And there are really good examples, right? Or just even like big businesses that bring flu vaccine to their employees because they want their employees to stay healthy and they make it easy for them. But how do you expand those kinds of efforts to get more of that sort of private sector in the game is I think where we need to move to, and I think it will help in the long run too. Then if you have the next disaster, you just have those relationships where they can step in more easily. Because I will be the first to acknowledge we are not efficient in government, and we need to work with partners more to help be more impactful, especially in an emergency.
Time for one more question.
So I worked with the federal government during the pandemic. And one of the things that we actually tried to do was to try to develop masks that were easier to wear, easier to breathe through. And we actually had a challenge and we had test those things. And there were 3 winners and there were all of them incredible. As protective as the N95, very easy to breathe through. I still own one of them. But I see the masking market just as broken as the antibiotics market, just as broken as the diagnostics market, because of those companies, only one is still even solvent and barely so. So how do we engage into, I mean, you know, in the federal government, we talk a lot about a warm base of manufacturing, things like that. What about a warm base of accustoming people to wear masks whenever they're a little sick or something, right? The idea, the culture of how masking should be done. I remember literally going into a Target, calling my wife and saying, oh, look at these idiots, because they're wearing masks. This was February, and I'm supposed to be some kind of an expert, right? And so I think that is something that, you know, those are the kinds of things that I think culturally we should be able to a little bit, you know, over time, be able to instill into people to be able to somehow fix those kinds of market problems, those broken market problems. And I would say the same thing for diagnostics as well. And I just don't know how one would really implement that and get everyone to go along in the kind of environment that we have now.
I'll channel Brian and say, was there a question associated with that? How do we establish this? Anybody comments? Great.
I mean, this isn't hopeful. I mean, I will say, I kind of feel like if we didn't get there after this pandemic, I'm a little concerned about what is going to get us there. It's kind of how, I mean, not to make it really grim, but it's how I feel about school shootings. Like, this was our attempt, this was our chance to get people in that mind space. And clearly we're not a culture that wants to do that. Now, I'm not saying you give up. I'm not saying it's not possible, but I don't feel super hopeful about it. And I do think it would take, it's clearly going to take some work if that's something we want to get at. It's not going to happen organically, or else I think it would have.
So from my limited view, like of my social circles, masking when you have cold-like symptoms has been normalized. You know, in a way, it was normalized in countries that had SARS outbreaks before COVID. I don't think that's representative of the country as a whole, but I'm kind of curious. You don't see any signs of that behavioral change?
Actually, that with masks that are strongly protective, that are just as cheap as surgical masks, that are very, right? There's really, it's like, well, if this mask looks different, so therefore I don't feel comfortable with it. I look weird going out in this mask. Something that is 1/10 protected.
There's a question from the chat. In your view, if a COVID-19 scale outbreak emerged today, how likely is it that the United States would experience disruption and health impact similar to those in 2020? In other words, how prepared do you believe the United States is to detect, contain, respond to a future epidemic or a pandemic of similar scale to COVID-19? We've got pithy answer from all three of you.
I do not feel super hopeful right now. I think it would be right now, if it were to be like tomorrow, I think it'd be way worse than COVID-19. Because I just think, I mean, the media industry, just from my perspective alone, we are exhausted and we are pretty devastated right now. And so just from my industry alone, it would be a big, tough call. And I can't even imagine what you're thinking there.
Yeah, I mean, I think, and to try to instill some hope, you know, there are a lot of tools we gained and learned, including actually thinking about masks again. Like we know for airborne diseases, there are these new tools and or just this idea of masking with good masks versus just completely shutting down. I think there's a lot of lessons learned that we could apply. And yeah, I think the public health workforce is exhausted. I mean, healthcare systems, I mean, there are, anyway, there are more and more rural hospitals closing. Like we have less healthcare surge now than I think we did then. Our data systems are probably somewhere in the middle, and depending where you are, as far as can we better collect that information, I think we are definitely further ahead than we were in 2020. And we still need resources to continue them, sustain them, and improve them, and catch up with like where other sectors are. But I am really worried about our workforce, though. I think just as far as, which again is, I've been making it a big priority to do like student talks and student interviews as much as possible, because I really want our public health workforce to stay strong. And there is data about, you know, the attrition that we've had, or even just thinking about my health officer colleagues, not only in California where we had more support, but across the country, there's just been incredible attrition. So I'm worried about that. And the healthcare workforce as well has had a lot of attrition. So yeah, it's I hope it doesn't happen tomorrow.
I think probably similar to Erin, like I'm very concerned about continued audience fragmentation in media. More and more people are seeking out sources of information that reinforce beliefs they already have and push them towards more extremes in those beliefs. And there is a whole anti-vaccine media influencer sphere that didn't really exist before. Yeah. I do have a question for Dr. Pan, though. I seem to recall that early in the pandemic, there was a possibly unnecessary delay in getting enough testing capacity deployed for effective contact tracing, partly because of some fumbled balls at the CDC. And I'm curious if at the public health agency level, you have more confidence in your capacity to rapidly deploy tests in the case of another novel pathogen making a debut.
Yeah, that's a great question. I mean, a lot of those novel emerging disease tests have been very dependent on the CDC to then deploy and have the assays. I think there's been more rapid expand, like, and I alluded to this, but I will use Mpox as a good example. We did a better job, and the CDC actually did a better job with once we started to see Mpox coming to the United States, which, you know, again, talk about being tired, you know, we were just trying to like normalize COVID-19 to some extent, and then Mpox was our next big emergency. But the CDC not only like got the assays and I think got them correct, because I think, like you said, there was an issue, but they came up with contracts more quickly with private sector labs to have some surge and share. And I think in the past they've been, I mean, the other horrible backlog with testing, I remember, is Zika. And you had pregnant women waiting for their Zika testing results, and they were only happening in Atlanta, and they'd have to wait weeks. And that's really critical depending on when in your pregnancy you are to make this really critical decision. So I think there's been some improvements. And then I think academic partnerships are also incredibly important. And that was another great thing in California and many other places, I think, as far as more partnerships to try to either develop early and or expand surge capacity. But I think there's still work to be done. And I will say, though, I do think that's the one area, thankfully, right now at the CDC that has not been, I haven't seen sort of reduction in force there that's significant or loss of subject matter expertise there yet. But I think it's that scaling and surging that we need to continue to work on how to do better.
Well, thank you. 2021 was SARS. 2001 was SARS. 2009 was H1N1 influenza. 2012 was MERS, and 2019 was COVID. There's going to be another pandemic. Yeah. Thank you all very much. I'm going to ask Richard Scheffler to come up. And as he's winding his way here, I want to just thank everybody for coming. I want to thank Michael Liu for the really lovely comments he made, touching comments. I want to thank everybody who donated to this fund. A special thanks to Meg and Richard for getting this fund off the ground, making it happen. Special thanks to John and Sabrina Saunders John and Sabrina for really helping. And last special thanks go to Alicia, Elise, and Teresa. These are the guys who really made this happen.
Hello, Kay. I'm Richard Scheffler. I have a raspy voice, so I'll try to speak up as best I can. That's from 4 decades of lecturing at Berkeley in the School of Public Health. It definitely takes its toll. I was prepared to give a lecture today, but unfortunately, the program says that I only can make final remarks. So I'm a bit disappointed because I stopped teaching about 6 or 7 years ago, though I'm still quite active in research. And when you do research that long, you become an addict. So it's really hard to stop. And you just keep on going. So I'm definitely addicted to that. And so I'm here to say a couple of things, but I just want to say that I'm, in listening to the panel and Dr. Pan, I sense that there's something going on that's a lot deeper than we've actually talked about. The positive thing about having a pandemic is people actually found out what public health is all about. When I came to the School of Public Health, I actually didn't know. They said, well, let's hire an economist because we think it might be useful to have one around. Of course, now we have too many of them. And so the sad thing about it is they know what public health is, but public health is under attack. We know it at the federal level, state level, and even the local level. And it's the people who think Americans are individuals. And basically, they're capitalists. And capitalists do what's best for them to make money. Public health people believe in solidarity. That is, we're all in this together. And these two things are pounding at each other. And what we've heard from the panel is solidarity is falling apart for political reasons and gain. So the school now, to me, has a bigger role to really establish how important it is to care about each other and to have solidarity with each other, as countries do in Europe, as we know, and all over the world. So I think this is a turning point. In Chinese, as Radin knows, crisis is opportunity. This is the opportunity to really redefine ourselves and move in a positive direction. And so we have a leader here, John Swartzberg. And also, when you get older, you think about philosophy. When I was young, I thought about philosophy. When you're older, you think about philosophy again. So I believe that things are predetermined in the world. And we're all going to play our parts in it. So I ask you, why is this lecture today, March 30th? Well, it could be that tomorrow, other than being April Fools, is also the first night of Passover. What is Passover about? It's about the Exodus, and it's about the 10 plagues. And so we have John now, and in the lecture today and Michael's introduction, we learned a lot about John as a professional, an amazing public health figure who was there for the public when the public needed him. But there's another thing, as a friend of John, and there are other friends here in the room, that John is even more important. John is what we call a mensch. How many people know what a mensch is? A mensch is someone who is an honest person, someone who cares for other people, and someone who does things for individuals and the public without any hope of any reciprocity. That's really what a mensch is. So, John, you are the mensch we're here to celebrate. And to do that, it's my honor to give you a plaque if someone can give it to me. Yes. So come up here. So we can get a photo op. So this is a plaque that says Dr. John Swartzberg in honor of the inaugural Berkeley School of Public Health lecturer. Let's have a big shout out for Dr. John Swartzberg.
Thank you, enough. Much appreciated. We have refreshments outside. Again, thank you for being here. Thank you for making this possible. Hopefully that we'll have many years of these lectures in public health infectious diseases. Thank you, Erica. Thank you, Erin. Thank you, Brian, very much.